Ladies and gentlemen, it is a real pleasure to welcome you to Munich. As a German, I'm proud that we have the World AIDS Conference here. I hope it enters really fun dialogues and interaction, and you also have a chance to visit wonderful Bavaria, because as you know, Bavaria is not really Germany, that's what they say at least. And it's a little different. You will see when you go to the breweries and have the meals, it's all a little different. But it does have one of the most beautiful sceneries. You will see the beautiful lakes and the mountains, and I just can encourage you to go and take that home as well. Now, my talk is going to be on long-acting PrEP clinical trials and real-world data, so it's really around prevention, and these are my conflict of interest. And so let me start off by highlighting why could we really need long-acting PrEP? Well, oral PrEP has not worked equally well for all at-risk populations. You know that particularly in women it didn't work that well. This may also explain why the uptake is much better in males than in females. Adherence or stigma challenges may be addressed with long-acting agents. That's something we learned from people under HIV treatment, that they enjoy long-acting, particularly to get rid of some of the stigma aspects. But it may also help to increase protection during sex acts unwanted or simply being unexpected or not perceived risk. Because it will ensure a tail of protection which will then be present. So it clearly adds something to a daily intake of an oral tablet. And it may also ensure protection during alcohol or drug use, which is difficult to control when you have to take medicine at a very defined time. Now, there are various long-acting agents which have been studied for use in PrEP, among them cabotegravir, which is administered intramuscular every 4 to 8 weeks, and that's something which is already available. Lenacapavir, subcutaneously every 6 months. That's something which was just addressed by Sharon, that will be presented by wonderful Linda Gale at the conference co-chair's choice session. And then you may know that there also is a depivirin monthly vaginal ring, which is available in Africa at least, and is recommended by WHO, which adds a different layer of potential control of females protecting themselves against HIV, and I think that is also sort of a different asset in our toolkit for prevention against HIV. And then I think we all were very eager to learn, under consideration of the complexities of implementation of long-acting devices in clinic, that there may also be oral formulations once monthly, which obviously also be quite attractive. And you may know that islatravir, one of the newer agents, NRTTI, was developed also in a PrEP program, but then there was an unforeseen lymphopenia in these patients, and so there were some hematological changes, and obviously in a healthy population, that's something you cannot develop, and so that was withdrawn. We're now looking at islatravir still in the context of treatment, but in different dosages, and obviously not with a long half-life and higher doses you need to ensure a 4-weekly protection. But there is a new drug in development from the same company, MK-8257, so that may be a new alternative in that perspective. Now, as you can see, PrEP clinical recommendations have moved on over time, so starting obviously with TDF-FTC, and I have to say this because being in a country where I can tell you in the beginning the government was absolutely reluctant to even talk about TDF-FTC, and it was part of that National Advisory Committee, which I was part of, to sort of highlight there's a need to bring that to the table. And it all changed when we had a gay health minister in place who personally felt that his people were concerned to make this change. It obviously helped tremendously that generic TDF-FTC became available because the price dropped dramatically, allowing much more easier discussions about the introduction and to have that being reimbursed by health insurance. I think it's fair to say, though, that this very low price of TDF-FTC comes at a cost when we talk of newer therapies where people want higher prices and health insurance companies will be reluctant to offer these advents to people requesting different modes of administration because the price is going to be eventually higher. So that, I think, is going to be one of the big challenges in this whole discussion. We already see that with the different TAF formulation, where we also were not able to secure financing of TAF in Germany for PrEP purposes, although in people with renal impairment, this obviously would be of clear benefit. But you can see that cabotegravir long-acting has already been added to the guideline recommendations from ISUSA and DHHS. The vaginal ring is also recommended by WHO, and WHO also recently has added cabotegravir. So we are having an increasing asset of drugs, but in the context of what Sharon said, which I think is very meaningful, looking at the goals we're not achieving, obviously all these tools and recommendations are only going to work when we have these drugs in our hands and use them properly, which also means no waiting time for PrEP and access for everyone for these therapies. Now, to give a little bit of background information, I'm sure a lot of you will know that, but just to sort of fill the picture of data we had, which led to the registration of cabotegravir as our first real long-acting in that sense, you can see that the phase 2, phase 3 development and subsequent implementation and real-world studies, it's a rich portfolio, and I'm not going to be able to cover all of that in my 50 minutes. I'm going to concentrate on the phase 3 registrational trials, which come from the HPTN network, 083 and 84, looking at different population, one targeting MSM and transgender women, and one looking at cisgender women in a certain age range between 18 and 45, and the study design was quite similar, so it was really a comparison of, in the injection phase of cabotegravir, long-acting 8-weekly in both studies versus TDF FTC as the oral control arm. And what came out after a year of unblinding was that the long-acting demonstrated superior efficacy, which I think was a surprise for many people and obviously changed the discussion and the use and value of these long-acting therapies. And then an open label extension phase continued. And if you look at the combined blind and unblinded phases of these phase 3 trial program, you will see there were 73 participants who acquired HIV under TDF FTC versus only 25 participants who acquired HIV in the cabotegravir long-acting in the 083 trial, and then in the 084 trial was 56 versus 6 participants. So a clear, significant difference telling us that this is obviously adding something to our prevention armamentarium. And as you would expect, the main reason for that is adherence, and you can see that the amount of individuals who had covered high levels of adherence to long-acting was, as you would perceive, with something which is in your body for 8 weeks, is going to be significantly higher than people who are taking oral medicine, which is easier to forget, and that was found in dry blood spots as well as in plasma examinations. So clearly long-acting provides an adherence advantage, and that's how we should use it in those populations where oral therapies are challenging. Now, one of the special outcomes of the study, though, was that there was a description of infections in the setting of long-acting early viral inhibition, which was called the Levi syndrome, which means that there were some individuals who got on-time injections but still developed an HIV infection. So obviously you have the one group, which you have in every trial, which sort of already have smoldering or just had HIV seroconversion, maybe no symptoms, and are still negative in the antibody test, and then enter the trial, and so they get the drug on already occurring HIV infection. That's one group. But then you also had some who, despite having on-time injections, did develop virological failure. And that has some consequences, because if you stay on that regimen and you get HIV infected, then obviously you're going to develop integrase resistance. And remember that integrase resistance is very harmful in the setting of a region in the world where integrase inhibitor-based therapy is your cornerstone of antiviral therapy. So that means that it does require the implementation of viral load testing in the cabotegravir administration in a certain way to at least prevent development of resistance in those who are positive. And that means that you have some extra cost diagnostically, which may also be a challenge in the implementation of these programs. Also note that clinically, this so-called Levi syndrome is distinct from what we would consider clinically to expect from an acute HIV seroconversion. So you have a smoldering infection versus very high viral load in the setting of acute HIV. Acute HIV often comes with the symptoms, and we know that has something also to do with the risk of further progression, whereas clinical symptoms in the Levi syndrome are mostly very minimal, which means that you can easily miss that as well, and that will then increase your risk of potential resistance development. So there are some issues there which need to be discussed. Some of the very few real-world use, and if there's little real-world use, tells you that implementation is difficult, so obviously some challenges, but from those cohorts, and the PrEP cohort from the US is one of those which has looked at the use of cabotegravir long-acting across 101 clinics in the first 6 months when it became available, and they have almost 500 individuals who had more than 2 injections. You can see the discontinuation rate is relatively small with 7%, but still sizable, I would say. And you can see there's still some with delayed injections and missed injections, so in real life it may be a little bit more difficult than in randomized clinical trials, but the amount of HIV cases reported was very, very low, which is reassuring that this seems to work very well in real-world setting as well. What I want to highlight is that what I've learned in the preparation of this talk is when you look at some of the other real-world data, I came across a very interesting study here, which was just published recently and also in a subsequent analysis presented at CROI this year, which looked at what they called a dynamic choice of HIV prevention, which goes beyond just the choice of a PrEP regimen, but also includes what kind of HIV test you're using. Is it a self-test? Is it a different form of testing? What kind of service do you attend? Is it more medically driven? Is it a community service? So telling that all these choices you have, and the more choices you give, the more likely it will be that people will actually subscribe to such a program and actively participate in protection. So choice is a main driver of coverage of these regimens, and I think that was kind of reassuring if you compared at least to sort of control average PrEP administration at a clinic. And when cabotegravir was added into the mix, over half of the participants in this intervention trial used long-acting, and that was true for men and women. And 42% of those who started cabotegravir were not on any prevention product in the prior month, telling us that obviously long-acting offers something new for some people, which brings people without prior protection into the use of using pre-exposure prophylaxis. And you can also see that the incidence rate in that intervention arm with the more choices was associated with a lower with a lower incidence rate of HIV, which was statistically significant difference. The big challenge, though, is obviously that although cabotegravir has been recognized by registrational authorities, EMEA, FDA, and so forth, the countries who actually have it in place is still somewhat limited. You see the current status of regulatory approval, so that is in different continents and countries, but most of the countries you see on the map don't have it available because, for example, in the context of Europe, means that you're going to go through a registration process where they're going to decide what the price is, and that will depend on the comparator. So they're going to say generic TDF FTC only costs that much, and so how can you show an added value? I think we would all agree that the registrational trials showed less infection, so there must be an added value, but it's very difficult to demonstrate in this cost procurement process, and that means it may be difficult and will take time before these advances of medicine are actually reaching at least the German and some of the other European populations. I just want to highlight because dapivirine is used as a ring, as a WHO recommended additional prevention choice for women. There was an interesting study from Africa, and unfortunately I forgot to list the reference. It was just published in Lancet HIV, and I think it's an important study because, again, it's including a very vulnerable group where we have little data, adolescent and young women from Africa who were randomly assigned to the different prevention methods and then also had a choice period. And it's interesting to see that the majority actually went for the ring, telling us that it adds something where women have the feeling that they can control their personal protection in a different way. And I think that's giving some gratitude to this, or gravity to this kind of intervention. The efficacy was comparable between the two regimens, and the adherence was what they said. Their conclusion of the paper was moderately high, but was only 57% in both groups, still highlighting that there are obviously issues to overcome. Let me just finish with lenacapavir. You know, a lot has been talked about the drug, the particular long half-life and its different properties, which allow us to really think of this exciting drug in different concept. You heard that the PURPOSE 1 study, which included over 5,000 cisgender adolescent girls and young women, and from South Africa, mostly South Africa, and also 3 sites in Uganda, over 5,000 individuals who participate in this trial, that the DSMB met and released the data from this trial, which was a comparison of lenacapavir subcutaneously every 6 months versus FTAF or FTDF in a 2-to-1 randomization. And the DSMB closed the study and recommended that the study everyone should be offered lenacapavir because of the significant difference. And it was really striking to see there were absolutely 0 infections in the 2,134 participants who received the long-acting lenacapavir, which was compared to the background HIV rate, which was higher, and it was also higher for the 2 oral arms. So again, we should all go, and I'm sure we all will, to the co-chair's choice session, because that will summarize issues around safety, when was the analysis done, and all these kind of things we want to know on top. Just finishing off with what I said in the beginning, I think there's still room, because of the implementation issues with IV or subcutaneously administered substances, for an oral drug, and that NRTTI was presented at CROI with a half-life of over 216 hours. So I think we have a promising compound, and let's just keep fingers crossed that it will be safe. So let me summarize that long-acting injectables clearly represent a new additional option for HIV prevention in people at substantial risk of HIV infection, which will fill gaps we have with our current PrEP regimens with regard to uptake, adherence, and retention. But again, if we can't implement these regimens, they're going to be useless. So we have to think of how can we put that into broader access. Clearly, CAB has been shown to be safe and highly effective and well accepted, but we have to deal with the occurrence of breakthrough HIV infections, what that means for resistance emergence. And then I think it's at least reassuring to see that more long-acting agents are on the way. So hopefully that will lead to further progress in this area. And with that, I'll send you a friendly hello from the Bonn group. Thank you very much.